Okay, well, I think we're going to go ahead and get started. We have an hour and we have a lot to get through, but I think the whole goal of this session is really just to have some Q&A and some discussion around credit and your experiences, which we heard from some of you at the CCD meeting, and what we should think about as we move forward. So was someone advancing this? Oh, Debbie, you are. So I'm Veena Shankar, and I'm the PI of the credit study. And I think that folks can go ahead and also put in questions in the chat that we can get to later during the Q&A. Okay, there we go. So just briefly, our goals of this session. First, we're going to actually just give a status update of the study and kind of review the eligibility criteria. I know many of you have seen them before, but just so that we're all on the same page, especially since we anticipate there's going to be a modification coming out to eligibility in the not too distant future. And we're also going to hear from our partners with SENS and PAF, the two organizations that are actually delivering the intervention. Tony Leahy is here in person from SENS, and then we have two folks from Patient Advocate Foundation who will be on Zoom. And then we're going to hear from panelists, so representatives at some of the sites, and about their experiences so far. And then we'll follow it up with a Q&A. Next slide. So here's just our timeline. So we're going to try and spend a good 20 minutes towards the end for Q&A. All right, so let's just dig into the study. I think those of you who were at the CCD session earlier saw this slide just as a refresher. Credit is a randomized study enrolling patient and spouse caregiver dyads to either an intervention, which consists of financial counseling and navigation provided by our partner organization, SENS and PAF, along with financial literacy training, given over the course of 6 months with monthly contacts with each of these organizations versus a control condition of financial literacy training alone. We're going to be stratifying the randomization by a number of factors that you see listed here: age, gender, and the type of cancer, as well as the household financial fragility level, which is essentially self-reported couples' ability to come up with $2,000 in 30 days for unexpected expenses. Our study assessments will happen at baseline, 3 months, 6 months, and 12 months, and will consist of a combination of questionnaires and then credit reports pulled for both the patient and participating spouse caregiver. Next slide. The primary objective is to determine if this program decreases the risk of material household financial hardship, so financial hardship at the household level over 12 months in patients and spouse caregivers. And I just want to quickly address why we are focusing on married dyads for this study, because this has come up. We've heard the feedback from many of you at various sites. And I think this is kind of an open conversation. For right now, we want to try and move forward with married dyads only. The scientific reason for this is that we are trying to determine whether the intervention improves household financial status, and we wanted to be very consistent in how the patient and caregiver were connected financially. And so this is why we have stipulated that they should be married, completing married filing jointly tax returns, and so that when you're looking at household financial hardship, you can be sure that this is actually a shared experience. I think that we would certainly argue that the financial hardship does not only affect married couples. Obviously, you could argue that there are other individuals who may be perhaps at more risk. And we certainly think that interventions focusing on other populations that are not married are critically important. And it may be over time we want to relax this criteria, but I don't want to start there, and open to feedback, certainly. Next slide. So in terms of the eligibility criteria, I'm not going to go through every single one, but I wanted to focus on some of the changes that are upcoming. So you all may recall that for this study, patients have to have either metastatic solid tumors They could have had an earlier stage diagnosis, or hematologic malignancies that are requiring active therapy, not patients with indolent hematologic malignancies on observation. But the way that the criteria were spelled out before was that it would kind of exclude people who were who had been diagnosed with indolent hematologic malignancies a long time ago and then progressed to requiring treatment. So we're changing that to allow for people who've had longstanding indolent hematologic cancers that then progressed, provided that the progression to requiring treatment happened within the 120-day diagnosis window. Does that make sense? Okay. The other thing is that we had previously said that patients with earlier stage solid tumors are eligible if they recur, so long as they are not on active therapy. And because, as you might imagine, there are a lot of women with breast cancer who may have been on hormonal therapy for years after the earlier breast cancer diagnosis, we are actually going to eliminate that requirement that they are no longer on active therapy so that we can be more inclusive. And I think those modifications have been submitted or will be soon. All right, next slide. Okay, so that's all for the eligibility and schema and so forth, and we can talk more specifics during the Q&A. But I'm going to hand it over to Tony Leahy, Executive Director of Sense, to give an update.
All right, well, thank you for having me. I work for a nonprofit called Sense, and like Dr. Shankaran talked about, we are part of this program. So I'll just give you a brief overview of Sense and then what we're doing with the study. Sense is a 501c3 nonprofit organization. We have a variety of programs and projects for various audiences. Our mission is to help people improve their financial health, and all of our programs are free of charge to the consumer, or in this case, the patient. Just a sample of our other programs, we have programs for senior citizens to help them identify and avoid scams. We have programs for people who've experienced incarceration, basically a financial reentry program. We have programs for high school students, how to wisely finance your post-secondary education or training. So we've been partnering with the Hutch on research projects for at least 5 years. And so this one, we meet with the patient and spouse once a month for 6 months. And these are the topics we cover. With our first meeting, it's a meet and greet plus. I get to know the patients. I tell them, remind them that this is confidential. I let them know that I'm in their corner and there to help in any way I can. I let them know that, my goal for them is for them to emerge from treatment as emotionally, physically, and financially healthy as possible. And, I let them know that I can answer any questions or concerns they have. So what I do is I provide them a few forms and we go through those forms. And again, I am really gentle with, these are at your convenience and when you're able. But I let them know that for us to provide some information and options, it's helpful for us to have a context of their financial situation. So I have a budget form that I have them fill out. And then I also have them fill out a balance sheet, basically assets and debts. And we take a look at those. And then I try to make it as patient and as possible, patient-centered as possible. So I'll start off with, any questions or concerns you have, and we take it from there. And I follow their lead. And then if anything pops up, any issue spotting that I see, I raise that as well. Our meetings are, 30 minutes to an hour once a month. They can email me in between that. The meetings take place via Zoom or a phone call, and then later meetings can be an email. So I guess one, and we do have Spanish language support available as well. I have a small team of mentors that if there is a issue that I want, a second set of eyes on, I reach out to them as well. So veteran financial planners or debtor creditor attorneys to talk with different issues that I see. The goal of the project, is to just put the patients at ease. As you can imagine, patients are overwhelmed and stressed. So again, I try to, take off the pressure and just let them know I'm here, and we can spend the time they have with me any way they want. If it's filling out the budget form, we can do that. And just kind of a no guilt, let's problem solve and troubleshoot and strategize together situation. And just as one example, we had a patient who was really nervous about if he passed away, would his wife be eligible for his Social Security benefits. He was under retirement age, she was over retirement age. And so he had he couldn't find the answer for that. So we researched that issue and found that even though he's under retirement age, he had worked enough in over 10 years to pay into the Social Security system that she could access the benefits, the survivor benefits upon his death, and then also switch to her benefits at some point later. So we kind of walked them through that, and they were super happy about that. And just little things, just from my own life too. There are some things when you're overwhelmed or too busy, you just don't do. And sometimes it's nice just to have a helping hand, walk you through that. Another example, we had a patient who got a will, but they weren't sure that they did it correctly. So we found some legal resources for them to just touch base, just to make sure, they did that correctly, just so they can rest at ease. And, that's some of the patients too are fine financially, but just hearing that, puts people at ease as well. So I'm really glad to be a part of this program and look forward to working with the patients we have and more patients and their spouses. So thank you.
Thank you so much, Tony. And I just mentioned, to your point, I think that while our primary endpoint is looking at the actual credit reports, there are a lot of measures around financial worry and caregiver burden and stress and other things that some of the things you mentioned might actually hopefully improve. Okay, so I think we have PAF, Jennifer Obenchain and Beth Scott on the Zoom to give a presentation on PAF's role in credit.
Yes.
It's on this slide here.
One second.
Yeah, are they
Hi, good afternoon, everybody. It's Jennifer Obenchain from Patient Advocate Foundation. Thanks for getting the slide back up for Beth Scott and I. It's so great to be here today and actually talk to you guys a little bit about our organization. We have definitely been I guess we can really just kind of say a huge role of an impact for being here to be a support to patients. And Beth Scott is actually one of our case managers that works diligently with the patients. So I'll kind of turn it over to her so she can really kind of talk a little bit more. But again, we're so happy to be here for patients and part of this study as well too. So.
Yes. So my name again is Beth, and I am one of the case managers here at the Patient Advocate Foundation. I've been here a few years, and it's really something that I really enjoy, helping the patients. And, we help patients just like listed here on the slide, finding financial resources for treatment and medications, but cost, that can be physician copays, transportation expenses, medication copays, housing, utility cost. We determine eligibility for those financial aid programs that exist. And so the patients, to try to get them enrolled with other external organizations that may be able to help them depending on their diagnosis. So we help the patients one-on-one with no cost to any of the individuals. Patients only have to have one diagnosis that is chronic or life-threatening or debilitating. That's the criteria. So we work, again, one-on-one with the patients. We sometimes work to negotiate a payment plan with patients. If they come to us and they have, medical bills, we may reach out to providers and see if they can offer them a discount or something that might be more affordable in a patient's budget. We help with patients that might need helping to get enrolled into health insurance or access social programs, SNAP benefits, food stamps. They may determine eligibility for Medicare. We do that. Help them get enrolled in Medicare, Medicaid, Social Security income, Social Security disability insurance, marketplace health insurance plans, appeal denials when the patient is denied Social Security disability. Patients call us a lot and ask for long-term care services. So we try to see if patients may be able to access Medicaid waivers so that they can get some additional care in the home that may not be usually not covered by Medicare, but sometimes it is covered by Medicaid. I work on a team. I work on the appeals team here, as Jennifer said, a case manager 3. So we work on the clinical side of that. So patients can sometimes contact us and ask if they qualify for any kind of clinical trials. We help them with reviewing and billing any kind of coding issues they may have. Assist on all levels of insurance appeals for denied claims, denied medications. We work with the doctor's offices as well if they're not really sure about how to submit an authorization or what needs to be included in the authorization. Help patients if they're prescribed something off-label by doing appeals. Patients that are in the workforce can sometimes contact us and ask if we have, if we can help them with any long-term or short-term disability questions they may have, or if they need some questions asked about FMLA and COBRA, those types of things. So we do a lot of different things one-on-one to the patients, but going back to what Tony said, sometimes it's not just helping them with all the things that we have listed. Sometimes they just call us and especially with this case study that's going on now, a lot of the people that we contact don't always know exactly what they need. They might find that need months down the road. So the first time we call them, the first contact we make is with the caregiver or the spouse and the patient at the first contact. They may not know what we do here. So we have to tell them exactly what we do here at the Patient Advocate Foundation. Kind of explain to them exactly the same way that I explained to you of what we do here. And then kind of let them tell me what they might need. And they may not have anything the first time we speak. So we follow up with them monthly, sometimes via email, sometimes via telephone call, just depending on how they want that done. But for examples, I've spoken to several people involved in the study. And I can go back and talk to one lady about clinical trials, one patient who was getting enrolled into a trial, but her insurance wasn't covering it. So we talked about, medical appeals, but after that, she wanted to know how she was going to get there, how she was going to afford transportation. So those are things that people don't think about when you get a chronic debilitating illness. You don't think about how am I going to get to the doctor? How am I going to afford my child's daycare? How am I going to afford food if they're going to be spending the night? How are they going to pay for a hotel room? So those things sometimes come up later after our patients speak to us the first time, because the first time they're just thinking about, getting in with their oncologist, starting treatment, but those other questions usually come later.
That's wonderful. I'm wondering if we could get Beth and Jennifer up on the screen so we can just put some faces to the voices here.
Let me get my camera on and I can probably do that.
Oh, that was probably, no pressure to turn your camera on.
There we go.
I need to put you on the spot, but there we go.
I don't know if
Thank you. And there's Jennifer. I'll just emphasize here that something to what Beth just said, which is that I think one of when you're talking to potential participants, the key here is that most of the time, any kind of financial navigation that's done in oncology is done in a reactive way, where an issue is identified by the clinical teams or the patient or spouse or caregiver may ask for some assistance, and then they're connected with organizations like SENS or PIF or whatever resources are available internally. The difference here is that we're trying to introduce this early on, so in a proactive way, because, and this is partly informed by what we observed in 1417 that many of you participated in, is that these financial hardships tend to accumulate and get progressively worse with time. So even if they don't exactly know, and they say to you that I'm fine financially, it's important to emphasize that this course is unpredictable and they don't need to have any financial issues to participate. A lot of times you guys probably uncover things when you're talking to them. So thank you both. Okay.
Thank you.
So I think Ari will turn it over to you for panel. Do you want us to? Whatever you want.
You can go to the next. Well, hi, everyone. Thank you for coming to our breakout session today, and thank you everyone online. We're hoping to have a panel discussion with some of our site representatives, and we're very lucky also to have Barbara, our patient advocate, here today around the approach and consent process, particularly for dyads and particularly for spouse caregivers, because we know that's been a bit of a challenge for some of the sites. So we have Kelsey Fay and Courtney Brown, who are both CRAs from Illinois Cancer Care. And if you guys can just confirm that you're online and we can hear you.
I'm here. I don't know if you can hear me.
We can hear you. Yeah, thank you.
Perfect.
And then we also have Lauren Key, who's our research manager from Peace Health Bellingham.
I'm on as well.
Okay, great. And then Barbara, if you want to introduce yourself since you're here.
Oh, hi, I'm Barbara Segarra. I'm the patient advocate for the Cancer Care Delivery Committee and a two-time breast cancer survivor.
Thank you all so much for participating with us today. We'll go to the next slide. Maybe. And we'd like to ask first of the site panelists if you could just briefly walk us through your process at your site to identify, approach, and consent dyads to this study. And Kelsey and Courtney, I know you're both at Illinois Cancer Care, so if just one of you want to jump in and tell us your process, that would be great.
Sure. So my name's Kelsey Fay. I work at Illinois Cancer Care in Peoria as a clinical research coordinator. Courtney is with me. She has a lot more advancement. I have been working for about 7 months. She has been a clinical research coordinator for about 5 years. But this study was one of my first studies that I took on. Basically, what we do at our facility is we try to identify patients through a report that we run, and we try to show advanced stage cancer with marital status, hopefully is married. And then we rely on APNs and docs. We email them a little blurb about the study to try to get them a little bit more on board with introducing that study to the patient, just a little bit of, you know, this is a financial study, looking at some financial hardships doesn't mean you have to be in a financial hardship to be a part of this study, but just kind of taking that little blurb and then running with it. We did at one point cold call people, and it did kind of start sounding a little bit scammy, especially with social security numbers. So we've relied mostly on APNs and docs to give us those referrals, especially with this particular study.
Great, thank you so much. And Lauren, if you could let us know about your process at Peace Health.
Sure, yeah, I'm Lauren. I'm at Peace Health in Bellingham, Washington. We're part of the PCRC and core. And as far as our process goes, I should start by saying that our physicians have reviewed the study and they've authorized our department to reach out to patients independent of them. So that's made it easier to catch patients within the protocol specified window for enrollment. We screen all newly diagnosed patients at our various cancer conferences or tumor boards, and we're also screening every consult scheduled at our facility. for all of the studies that we have available at our site. And we've added S1912CD to that list of studies. So while we're reviewing these cases, we've been keeping an eye out for metastatic or recurrent patients that fit the eligibility requirements of the study. And then when we identify these patients, we do a brief search of the medical record to determine whether or not the patient is married. We have a couple places that we look for this information. The demographics page in the EMR is a good starting point, but it doesn't clarify between spouse and partner. So we also look at, we have an alternative communication form that the patient fills out themselves, indicating who we can reach out to and what their relationship to the patient is. So that's a good place to figure out if they're married. And then another place that we found helpful is social worker and nurse navigator notes. They generally have a well-established relationship with the patients, and when they note spouse, it's generally accurate. When we approach the patients, we use the study provided patient brochure with our cards attached to help us summarize the study. We've both approached patients ourselves as the research department, and then we've also worked with our navigators to present the study to patients that way. If patient and spouse are interested, we meet with them and give them a copy of the informed consent to review. And then we also use this time to kind of verify some of the eligibility requirements, double checking marital status, that they live in the same house, and that they file joint income taxes. And then once that's verified, we coordinate another time after they've reviewed the informed consent to sign and get them enrolled. And we usually make the plan to meet them at their next scheduled appointment so they don't have to come in for any additional visits.
Great, thank you so much, Lauren. Barbara, I'm curious what advice you would give to sites on approaching dyads versus individual patients for recruitment.
Yeah, and I have a question for the sites later to see, what questions patients have made. This study has two elements. First off, talking about clinical trials, still a lot of patients don't understand what a clinical trial is, right? And then in this particular trial, we're dealing with two sensitive issues, right? About Social Security and financial reports, credit reports. And secondly, this issue about being married, right? Especially people, I think patients could feel judged if they say, this is my partner, I'm not married, depending, if you ask somebody 20 something, maybe it's my kid lived with his girlfriend for 5 years now, and I don't think they're never going to get married, but it's about its difference, right? And when you go, also a good thing about this study is that it's for Spanish-speaking people as well. So you get there into the cultural issue. And for a lot of Latino communities, men are still they conceive themselves that they have control of the financials. Nobody will ask me. No, that's nobody's business. And so this could be a little difficult for that people. So I think it's important for the couple to be together and receive the information, because what a patient can tell them or the question they might have, maybe the patient does not know how to answer. So, and the matter that is possible is better to kind of introduce or have the general idea of what the study is about, and then have them together. This study, I reviewed, for example, the educational material, and it's amazing. I've been a survivor for 18 years, or it's almost 18 years now, and I learned a lot, just how to read the insurance bill. I didn't know all the codes and all those things. So just reviewing that material was very important. And I think it's an issue that we can share with the participant, that even if they're not randomized to these organizations, they're going to receive material that will help them. And then at the end, on the learning, then again, I have never heard about these two organizations and the great work that they do. So this is a huge need. This is a great study, and people don't realize, how, especially if they had cancer before, how these things, as Bina said, keep piling up. So it's the matter we approach them. And I was reviewing the materials that we have to recruit them. And I think if we're going to continue with the criteria of them being married, it should be there. So people, since the beginning, if they're uncomfortable with that or they're not married, they know firsthand that they won't participate. And things that we discussed when this study was being put together, important to offer to everyone, and that the people understand that this is being offered. To me, if I live in Beverly here, or to me, if I live in a little town in Puerto Rico, right? So that is important, because sometimes people feel discriminated, or you're judging me, or yeah, I can pay my things, you don't have to offer me money for this, or I don't need help. So there's a lot of sensitive issues in this, but this is a great study, and we have to see how we encourage and how we approach patients also. Depend on what moment. If they just got to the appointment where they are told, yeah, you're metastatic, or yeah, you have, they're not going to think about anything else of right now, right? So these things have to be in the right moment, and I think the coordinators are crucial for this, because the way they are approach the patient is gonna be a yes or a no immediately.
Yeah, thank you, Barbara. Lauren, if you could just tell us a little bit about what's been successful about your process in approaching and consenting patients. And I'm also curious if you could talk a little bit about, you said that you ask or verify with patients that they're married or filing their taxes jointly together when you have those conversations at consent. If you could just shed a little light into how those conversations have gone, and how you've sort of phrased those conversations, because we have heard that as a barrier.
Sure. What was the first part of the question?
Oh, what's been successful about your process?
So I think that the greatest success that we've had is we are able to, so our department is connected to the cancer centers, so it makes it really easy for us to catch patients at different time points. So we keep a list within our department of potential patients that are eligible. We note the last date that they could possibly enroll, and then the next time and date that they're in the clinic. And so anybody within our office can jump over and try to catch them at either like an infusion visit or a MD follow-up. We've probably had the most success approaching patients while they're in infusion getting treatment. Generally, their spouse accompanies them at these appointments, so it's a good time to talk to both potential study participants to gauge their interest, and then later on to have them sign informed consent and enroll them at that time. We've also had them do the baseline requirements during the infusion visit as well. As far as if there's any doubt of whether they're married or not, I will kind of use the infusion nurses to help me verify, because I don't want to, the first time I'm meeting a patient, say, hi, my name is Lauren, I'm with research, and are you married? Like that doesn't work. So, so I kind of get the inside scoop from infusion nursing, because typically we're not approaching them at their very first infusion. I kind of agree with the fact that like when patients are first diagnosed and they're getting their first treatment, like it's all just so overwhelming. So the benefit of having the longer enrollment window is that we can catch them at maybe like the second infusion, where they have had a chance to kind of settle into the process, and then give them the information of, hey, this is a great study and this is what is offered. And it seems to be pretty well received that way. Did I answer everything?
You did, yeah. Thank you so much, Lauren. Sorry to throw some extra questions there your way. Kelsey or Courtney, could you talk about what's been successful at Illinois Cancer Care in your approach and consent process?
Sure. So this is Kelsey. So we try to emphasize, like I talked about, looking at a variety of patients, not just ones with financial hardship. When we first started approaching patients, that was one of the things that turned people off, I think, the most. Starting out, like just a conversation was, I don't have financial hardship. Okay, well, we're actually taking a look at all types, because otherwise this would be skewed data. So that's one of the things that we've tried to emphasize. The other one that we've really tried to emphasize is, although you might not be paid for the study, you could get financial counselors, which normally people pay for free. And these are live people that are tailoring conversations to you and your spouse's needs. and that this could be a benefit not only for you, but possibly something that we could implement at the start of people's cancer treatments later on if this proves to be successful.
That's great. Thank you very much. On the flip side of that, Kelsey or Courtney, what are some challenges that you guys have faced? And we would love to hear also if you've come up with any solutions to those challenges.
So I think our biggest challenge, which I'm sure everyone can probably understand and have the same issues with, is the two things: Social Security numbers giving out, and then also the soft credit checks. The Social Security numbers, we've had a few people that have actually had their Social Security numbers stolen, and they just don't even want to start that, again, process of trying to give that out. Very nervous about that. I did actually have someone that, even though you tell them that it's a soft credit check, majority of people are turned off by that. I did have someone that was willing to sign consent for the study, but did not like the fact that you would have to pull a soft credit check, and really didn't understand why he couldn't give his credit score that he gets monthly from his credit card actually gives him a monthly credit score, and why he couldn't just give that to study. So that was one thing that I told him I would definitely bring up, and since I'm on the panel, wanted to share that. But those, as most people probably are having, are our two biggest caveats to not getting people on to study.
Yeah, we've definitely heard both of those before and appreciate that perspective. Lauren, do you have anything to add to that about any challenges you faced at Peace Health?
No, actually, I haven't experienced any of those challenges. The main challenge that we've had is just determining marital status and bringing it up in a socially not awkward way. And then, but we, I've kind of already talked about how we dig and try to figure that out before we ask the patient. And then the other challenge that we come across is, I think I will move forward with kind of a solution from this panel, is we've had a couple patients decline participation because they don't need financial assistance in their eyes. But I'm going to definitely use the verbiage that's been used today and try to encourage people to participate regardless of that in the future. So.
Great. Thank you so much. Barbara, do you have any advice on how to approach that conversation around the requirement to be legally married or to be filing your taxes jointly?
I think it's when the study explain why that is important, right? It's not because I want to know if you're married or I want to get my nose in what's happening in the family. It's because this is part of what we want to understand in the study. So I think that information is very important to share to the whole concept, and I'm happy to but that you mentioned, people don't realize what even financial toxicity is, or hardship, or if you say that in Spanish, I don't know how you would even say that in Spanish. You will say embrollado, we have money, that's up to here, whatever. But I think the important thing is that we have said, and Vina mentioned, how is this to prevent you to get there? And that maybe if you're in the beginning of this journey, you don't realize all the ads in that are gonna come in, or other part of the things that the videos and and this project does is finding alternatives that patients don't know. I have friends that don't know that if they cannot pay for a medication, I used to have a nausea medication that it cost like $500, and a lot of insurance didn't cover it by that time, but the company did, the pharma did, but a lot of patients don't know that. So these are the benefits, and I think they have to understand that whether they are randomized or not, they will have benefit with education and information. And we are always very worried about privacy, and my sons make joke of me when I say, oh, Alexa knows everything. And they go, Mom, they know everything because they have everything on Facebook, right? So I think we have to really have those conversations. What is privacy now? And then, what is the benefit for them?
Yeah. Thank you very much. Thank you to all of the panelists. We do want to make sure there's plenty of time for question and answer. So all of the panelists will be available. I'm going to ask Ina and Tony to come back up as well. And then we have Sam Zingle here as well, who's the data coordinator for S1912CD. And I'm not sure, can we see the chat questions as well? So at the top, it says eligibility. Please define the criteria for how this protocol defines metastatic solid tumor.
Yeah, so we've actually had a lot of questions around this because there are different staging systems within solid tumors. For example, ovarian cancer, I think this came up from one of the sites, a patient with ovarian cancer with mental mets that was going to go for like a debulking cytoreductive surgery. So I think in general, and we don't specify AJCC staging in the protocol kind of intentionally, but the idea is that the patient should have an advanced solid tumor. Ideally, it should be a metastatic solid tumor that's going to require ongoing therapy. That is the idea and the intent here. Now, I would say that if there are specific scenarios where it's unclear, maybe they have like an isolated MET and they're going for curative therapy, that patient is still eligible. Or if it's a scenario where there's a different AJCC staging system and it's not called out specifically stage 4, but they have a clearly advanced disease, that patient is probably eligible. You can certainly check with us and we can get back to you on a case-by-case basis if it's not straightforward. But we didn't define it so specifically exactly for the reasons that we want to be a little bit flexible.
Great, thanks, Vina. This is a comment and a question. It looks like the site has educated their social workers and nurse navigators to help introduce the study to patients as well. So it sounds like that's been successful for them since those roles are already talking to patients about those types of subjects. So just a success story there. And then the question is, how do you approach the Midwest culture of not talking about money? We had this come up in the CCDR conversation, Scott. I don't know, Tony, do you want to talk a little bit about your guys' approach?
The first thing I would say is that, you know, it's confidential. The study's confidential, so we're not sharing their information or anything like that. And yeah, I think I just try to let them know that for us to help them, you know, we have to have some kind of context of their situation. And then I try to also just, when I'm working with people, you know, open up myself too and talk about my situation in my life, and just, you know, it's a conversation and informal and private and confidential.
Could I just add one thing, not to the Midwest comment, but the so this has come up before. It is in the protocol that we are not replacing the resources that are available in the clinic, whether it's the social workers, the financial counselors, or whomever, in either the control or the intervention arm. Patients and families can use whatever resources are available. We'll kind of be tracking that information from in the surveys to see if they're using the internal, you know, resources, but that's completely allowed. So this is kind of above and beyond what happens normally in clinical practice.
Sure, yeah, just so online can hear you, yeah.
I have two questions. One, do you ever have patients having a difficult time filling out forms, like you're helping them over the phone? Because how does that work? Like, I mean, I'm just thinking, like, do you have like attrition from patients, they just don't end up filling out the forms, you know, that's needed? Because I don't know, maybe that's a moot point, but it seems to me that might be difficult to get some certain, you know, some of my patients to be like, okay, you need to fill out this form, and you're trying to do it over the phone or over a Zoom or something. It might be a little tricky. Do you ever experience that?
I mean, we haven't gotten forms from everybody, but, you know, I guess I try to follow their lead, and if they want help to fill out the form, and then if it gets to the point where they ask a question where we actually would need one of those forms to give them, you know, a good information, then I could even just walk them through it on the phone in real time, and I could fill it out, you know, for myself. So we try not to let that be a barrier, but I'm sure that, you know, we haven't gotten every form from everybody. So we just, you know, we're a little bit informal on that until we actually need it. Then I might ask if we could advance on that together.
Okay, so it's been like, it hasn't been a big issue. You've been able to work through that then.
Yeah, not yet.
Yeah, good. Okay. And then the other question I have, because, you know, we have patients that, you know, they have a hard time making co-pays and, you know, things. So, but we have like our nurse navigators who help them, hook them, especially with the Medicare patients that aren't eligible for pharma, you know, assistance, and they have to go through the foundations. Is that something, like, I know our nurse navigator, we haven't opened the study yet, we're still in the process, but is it something that the Patient Advocacy Foundation is going to take care of? Would they help with that? I mean, I think there's still a lot of confusion around that. Like, so is that going to help the Nurse Navigator? Because the Patient Advocacy Foundation, the path's going to take that off the Nurse Navigator's plate. Does that make sense?
It makes sense.
Yeah.
I think that, so I would say to that, the Nurse Navigator should continue the process that they started, because I don't think that it's going to be, I don't think we can assume that PAF is going to
Okay.
take that on, because they're not, I mean, that is part of what they do, but they're not as involved in the kind of clinical workflow
Right.
as the Nurse Navigator is. Now, I'm sure PAF is still on, so Beth and Jennifer, please pipe in here. But my guess is that there might be scenarios where the process is ongoing. Maybe PAF can help and contact the clinic and help kind of work through that. Yeah, maybe I'll see if you guys can respond to that question directly, Jennifer and Beth.
Yeah, absolutely. That is definitely something that we do, especially with our touch points with the patient monthly. And we always make sure that the patient knows in between those touch points, anytime that something does arise. And in this instance, if it does come up with a copay, it is something that we can actually work with other nonprofit organizations, help the patient actually apply, find out what other resources that are available for them, and help them get that financial support that they're looking for. So it is definitely something that we can assist with, and it's something that Beth does talk to and kind of go over those scenarios when we are talking to the study recipients and kind of going over those as well. So,
And then after the 6 months, are you still available to the patient?
after the 6 months, yes, if we need to have any additional touch points, or if there's something else that they're needing help with, Patient Advocate Foundation is always going to be here to offer anything if we need to. So,
Thank you.
Right. So I just put that in the chat. I'm not sure if you saw that. Pretty much the same thing Jennifer just said about, yes, we do usually ask the question when we get the cases, if they do need assistance with copay and deductibles, or they have any problem paying their insurance premiums, anything like that. So that is something we do talk about on these studies, as well as all of our patients that call here. So if it is something that they need and we need to conference call the doctor's office or the Nurse Navigator there, we can certainly do that.
Thank you both. Could I just address those two eligibility questions quickly? So I think, Shannon, I can't recall the exact instance, but in the question is whether a patient with breast cancer with lymph node disease could be considered eligible. If the lymph nodes are axillary, it's like a regional cancer, primary breast cancer with lymph node metastases in the axilla, that patient is not eligible. It has to be a metastatic lymph node. And then to Lori's question, can you explain why patients who are only receiving radiation therapy are not eligible? This has come up a couple times, actually. I think so we're really trying to capture kind of the chronic effects of systemic therapy and all of the costs associated with it. Radiation may have a cost burden as well, and there's obviously the transportation issues, but it's a very defined course of treatment. So there may be patients who get radiation therapy and that get chemotherapy as well, or other systemic therapy, and it's within the window that we specify, which is 60 days, within the 60 days prior to registration or the 30 days after. And they can go on even if they get radiation as well. But just radiation alone, no.
I was, when they were asking, I think the point that you brought, that the Navigator should continue the work as is, because I know they're randomized either to credit or patient, right? All the patients are not gonna go to the same organization. So it's important not to assume that they're gonna get the help with one of the organization if maybe they're randomized to the other or whatever. So.
Well, all the randomized patients and caregivers will go to both
okay.
organizations. But what the nurse navigator may not know is whether they're in the intervention arm or the control arm. They may know that they're on the study. So I think that we should just, there may be scenarios where there's more cooks in the kitchen, and that's okay, because, that's
More than-
yeah.
Do we have any other questions?
My name's Jenny and I'm from Theta Care from Wisconsin. We do have the study open. We've been struggling a little bit to get our first patient. We've been trying. My question is more about screening and finding the patients. So, a lot of the screening is manual and going through the provider schedules. I'm interested in, I think it was Illinois that talked about the report, if by any chance you have Epic, and just some feedback maybe on anyone for screening for this trial, because that's kind of been our issue, is the time involved with screening for the trial, finding those patients. And sometimes it's finding them and then you spend more time digging through their chart and finding out you think they're eligible and then really they're not. So it's a lot of time commitment. So if there's any tricks or anything on finding those patients would be helpful.
Kelsey or Courtney, are you still on to address that?
I'm still on. Yeah, so we don't have Epic. We have something called Mosaic. We actually work with some IT people because we are a cancer center that are screening for a lot of things. We kind of give them the initial, like, here's a few of the criteria. Can you kind of, compile that into a report? I will tell you the report is not fail safe or fail proof, where it's going to be something I will tell you majority of my time looking at patients and also going through their charts, their patient registration to find out if they are married, making sure that they are advanced enough cancers, the 120 days from diagnosis, the 60 days from the actual start of therapy. So it does take me quite a while, and we have screened, I will say, probably 500 to 700 people at this point, and we've put 4 people on. So it is a very long process, and the report isn't something that is, saving time, but it's not saving us a ton of time. We're still looking through a lot of people's charts also. So hate to say that, but we don't have Epic. So I don't know if Epic has something different.
So just a comment on that. I guess I'm just curious, if you screened that many patients, how much time do you spend per week maybe or per month on this trial alone? So I'm a CCDR lead and I have other CCDR trials, and it's kind of that, how much do you spend on each trial? And so I have other trials that are very easy to screen, very easy to get accruals on. So that's kind of the problem that I have, so I'm just curious, when I hear that number, it's kind of hard to invest the time, you know what I mean, to only come up with 1 or 2 patients and screening that many patients.
What is the main reason for those going from 500 to 4? What is the drop off? Is it the marital status? Is it the stage? Just curious.
Are you wanting me to answer? Sorry.
Oh, yeah, sorry. Yes, thank you.
Okay, no, you're fine. So it is mainly not advanced enough, so not metastatic that we find. We do find some that were at our facility, say, a year or 2 ago, or even 6 months ago, and they filled out a registration form and their spouse has been widowed. The other thing that we find is a lot of older people that their spouse is still living but does not come with them to appointments due to the fact that they are in a nursing home, have dementia, not able to get out. We do see quite a big population of older people. So those are some of the things that we do. As far as the time goes, I would say on average, I have probably three to 4 studies that I'm screening, and I usually allot for a couple hours a day for screening those. studies. I've screened so many studies with a financial at this point that it doesn't take me as long, but it was taking me a little bit longer to start with when we first started because we hadn't screened. Majority of the time now I'm just running into people that are new to our facility.
And can I just ask Lauren, if you're still on, if you have any perspective on this question as well, if you guys run reports at Peace Health, if you're on Epic, if you have any advice?
We do not run reports. I mean, we've used Slicer Dicer in the past, but I'm not sure that I would like rely on that to pull the patients for the study. Well, at least the way I run it. But I mean, we're looking at all of our patients coming in. We have 3 nurse coordinators that work in this office, and we divvy up the screening. So every day we screen patients that are coming in, and we're already screening for our existing studies. So this is just one that we've popped in the back of our head of, oh, this patient's married. Maybe I'll see or, oh, this patient has metastatic disease. I wonder if they're married. So it's kind of an as we go screening. So we're kind of a little bit unique in terms of the way that we screen for trials in comparison to the bigger sites that maybe focus in on 1 or 2 studies. So I don't know that I have too much to add in terms of advice, but I wonder, would it be allowable to like leave the brochure somewhere where there's like patient resources and then like attach like a research card so patients that were maybe interested could reach out? I don't know most places policies on that, but that might be an idea.
Thank you, Lauren. I see someone's up here.
Hi, my name is Eric. I'm a clinical research manager for NCI Research at Columbia University. So we had actually started a very aggressive approach for this study since we had S1417 open and we were a pretty high accruing site. One of it was that we engaged all of our research meetings for all of our disease-based teams. And there was a lot of attractiveness for the study initially, and we were getting a lot of referrals, but eventually that died down, and we're trying to reinvigorate that approach. We also have a report that we have going through Epic, very similar to everybody else. Now, we've spoken to the Patient Advocate Foundation, and to Tony as well, spoke to part of our working group last week. We're also fortunate because we had a P30 that was looking at financial toxicity by implementing a 2-question screener in our breast oncology clinic. Now we're moving into the next portion of that study right now, and we are interviewing patients for that. And some of the patients, unfortunately, also have spouses. So we've been recently getting those referrals. But the thing that we found was the most interesting was that we tried to engage with our social workers about a month ago, and they were a bit more combative to this trial than we anticipated. And we're still trying to overcome that hurdle all the time, or currently as well. I think though, where we think the most momentum is to engage with our physicians, since this trial is so attractive. And Andrew is the coordinator who operationalized it, and probably give a little bit more insight.
Yeah, like Eric was saying, we also have that screening track list. It's been largely unsuccessful, probably a similar rate to 4 out of hundreds. But the most useful resource I think that we're gonna find, it hasn't paid off yet, so there's a little caveat to that, but the heme nurses I think are going to be really useful for us in that they get to speak with the patients. They will often get to hear about things like financial statuses or hardships or spouse, and then also the heme eligibility is just a bit easier, that they don't have to be metastatic, they just have to be newly diagnosed and on treatment. So we're hopefully going to see that pay off. The other thing as far as actual enrollment is concerned and the consenting process is that it does ask for some, in the patient's eyes, sketchy information from the point of, are you married? What's your social security number, etc. Having the doctor endorse the trial, not only endorsing the trial, but endorsing the coordinator as a trustworthy person and that we work together, not here's your treatment, here's your research. If that kind of feels more as one cohesive unit to the patient, I think that makes everything go a lot more smoothly. So if the MDs are not only endorsing the trial, but endorsing the coordinator, I think that makes this a easier process.
Thanks for that feedback.
Just to add on, I'm an advanced practice provider, and I always, say that we're kind of really involved with all the patients too, and just identifying like a clinical champion within your clinic, whether that's the doc, the advanced practice provider, the clinic nurse, the nurse navigator, maybe it's not the social worker. I know with social workers, I've been, really stretched during COVID. So, at this point, we're all stretched, but there's a lot of different clinical people that we know like what stage they are, what their treatment is, all of these things. So like we're a really good resource within your clinic as well. So I just wanted to say that.
Awesome. Well, I think we are at 2:02, so we're technically done. I will just thank all the panelists and Tony from Sense and Jennifer and Beth from PAF for joining, the clinical sites, Barbara, of course, and all of you guys for screening and all the hard work you're doing to screen and enroll patients to the study. And I'll just close by saying that we have definitely heard your feedback about the concerns, the eligibility concerns around the married dietes. So I think our next steps are to kind of bring this back to the investigative team and see what we can work with there.
Are due on June 1st, and so is your CCDR budget. So as you talk about the effort that it takes to do this study, please remember to reflect that in your CCDR budgets for the upcoming year.